Well, it is 4 o'clock. It's CWIS time or Mountain Daylight Time. Welcome, CWIS faithful to the case review series. Before we get started, just a couple of rules of engagement. First and foremost, questions are encouraged. So please make sure to submit your questions into the chat box, or feel free to let me know and we'll unmute you and have you ask your questions. The more conversation that we have, the more we all learn. So we really encourage questions from participants and speakers. Participants, please make sure you're on mute during your presentations. The way you'll know you're on mute is if there's a little red microphone with an arrow through it on the bottom left-hand side of your screen. The format, just as a reminder, we have 5 to 7 minutes per presentation, and then 5 to 7 minutes after the presentation for questions for each of the presenters. Another reminder, please register for the next CWIS case review series at the link below. We also have all of the prior CWIS case review series recorded at the same site. So if you have a burning question that you need answered, there's a good chance that someone else at CWIS has encountered the same thing. So take a look at the case review series archive that we have. And with that, I'm going to stop sharing and I'm going to hand it over to Dr. Michael Renda. To begin sharing his screen. Dr. Renda is an assistant professor of surgery at the University of South Florida, Morsani College of Medicine's Division of Trauma, General Surgery, and Surgical Critical Care. He's a practicing trauma surgeon at Kendall. So take it away, Dr. Renda.
Hey, good evening, everybody. Thank you so much for having me tonight. This is a great opportunity to share some of these great cases here. So I have, for our case presentation, and thank you, Dr. Forrester, for that lovely introduction. So I have here a open left flail chest, and obviously this is the Chest Wall Injury Society. And again, thank you for the introduction. So I was able to get some of the videos up, luckily. So hopefully you guys everyone can see what's going on the screen, correct? I just want to make sure I'm not talking to nobody here. Perfect. So this is our case description. This was a 70-year-old gentleman who fell from roughly a 10-foot roof onto a tree branch, which impaled his left chest. And he actually was a relatively healthy 70-year-old gentleman. His only history was psychiatric history with mental personality disorder, bipolar disorder. So he was not taking any medications and didn't have any significant comorbidities. This video was actually taken by me 2 days after his actual admission. So I'm going to go back to this slide to show you guys the video after I discuss his injuries and kind of what happened when he initially came into the hospital here. So his initial injuries was a penetrating injury to the left chest with greater than 20% blood loss, grade 3. These are all the AIS grading categories. He had a left open flail chest with ribs 4 through 6. He had bilateral pulmonary contusions and a left hemopneumothorax, and also a grade 1 cardiac contusion. I'll also come back to this video on this slide as well. So on CT, he had a moderate sized left pneumothorax with hemothorax with a small pneumothorax component. He had acute fractures of the left 4th, 5th, and 6th ribs with associated dislocation of the left posterior 4th rib at the costovertebral junction. And so I was planning to possibly do some extra thoracic plates on this gentleman. And these were some of the measurements we had taken preoperatively. So he came in on a Saturday morning, and his index operation with one of my partners was they placed a left-sided thoracostomy tube and they debrided his chest wall in preparation for that Monday morning for me coming in and doing the fixation. However, 48 hours later, like I said, this was Monday morning. I came in to see the patient. I got a frantic phone call early in the morning from the residents that the patient was hemodynamically unstable. So we took him, and he had a whiteout of his left chest. So we took him immediately to the operating room, and we performed a left anterolateral thoracotomy. We performed a pericardial window. There were 2 bleeding intercostal vessels that we ligated. There was a large left hemothorax that we evacuated, and we debrided that anterior chest wall wound. So this again, was the chest x-ray that I came to in that morning after his initial index operation on the Saturday, 48 hours later, when he was hemodynamically unstable. And then I want to take you guys back in time, because then again, this was the picture I took right when I walked into the room here. And this really exemplifies his left flail segment. So as you can see there, the paradoxical movement there with the ventilator. And then this is his CT reconstruction. I have a video of that for you guys. All right, again. Then this was right when I prepped and draped the patient preoperatively here in this picture. So we took the patient back several times. We continued to debride the chest wall. We closed his thoracotomy wound, had back and forth discussions with myself and my partners on, whether or not we thought that we should plate this gentleman on this hospital stay here. And post-operatively, again, at this point, this was right the day before he left the hospital here. As you can see, the anterior chest wall wound was completely healed in this picture on the left. And then this was the thoracotomy wound, which also healed nicely. And here's one of those lidocaine patches that we were talking about, which really don't do anything. Totally agree with you with that. So where are we now? Well, the patient's home. We're awaiting a possible staged plating procedure at this point. But the learning points, especially for early on in this case, I had one of my colleagues who's a burn and plastic surgeon whom we work very closely with. And, I was talking to him about tissue coverage and what we could do. Again, and then is there a role here for a staged procedure where we could maybe do this and bring him into the hospital if he's still having some pain. And he was a veteran, again, healthy guy from a physiologic standpoint. And he actually was all for having his ribs fixed when I discharged him. I haven't seen him in clinic just yet, but looking forward to seeing him and looking forward to your guys' comments. And this is one of our sweet new helicopters that we recently got. And again, thank you guys. Look forward to talking about this case and seeing your comments here. I see there's some questions already popping up in the chat here. So let me go through this here.
Yeah, so thank you very much, Dr. Renda. Yeah, there are definitely a couple questions in the chat, and I'd be happy, if you can't see them, I can read them out to you. I guess first and foremost, from my standpoint with respect to your tissue coverage, I mean, was there a lot of tension? That didn't look like a huge wound. So it seems like you may have been able to just raise some flaps and get it to come together.
Yeah, I think it would have came together, and it obviously did come together at the end of the day relatively well. My plastics colleagues were even talking about, coming in with me and raising like a pec flap or doing a rotational flap over this. Because when we first, we closed it subsequently over several trips and several bedside procedures where we did delayed primary closures and we had, the wound vac-ed, and eventually it finally healed on its own. But definitely in the beginning, the big holdup or concern from my partners was that this gentleman fell onto a tree branch. So this was considered a dirty wound, and they were very hesitant about me putting any type of hardware in this particular situation. So that was one of the big questions that I wanted to address with the society.
Great, thank you. We'll see if anyone. I know there's some more experienced platers on the call. Maybe they'll be able to provide some additional insight. I know personally, I've put plates in open wounds before, and as long as I've been able to get muscular coverage, I haven't had too many issues. Although my N value isn't as high as someone like Dr. White or Dr. K, who I see on the call. While we wait for them to weigh in, I see a question from Carrie, and Carrie was asking, and I'm imagining this is in relation to the decision for the thoracotomy. Why not transfuse an IR?
Again, he was unstable, and from that X-ray, with the amount, there was probably 1 liter to 2 liters of blood clot that we pulled out of his left chest. So I think at that point he definitely needed an operative intervention. He was actively being transfused, when we took him to the operating room. But I think just something got stirred up overnight there with these fractures that roughed up one of his intercostals or two, which we ended up ligating and getting control over. And then we just did the window for, to make sure that there was nothing going on cardiac in nature in this case.
Hey, Mike,
go ahead.
Sorry, Tom White. I was just going to comment on this case. It's a really terrific presentation. It's fascinating. Is there a large chest wall defect, or is it just that the bony instability is really the residual problem?
So right now there's no tissue defect. There's no tissue loss. Like, as you can see in this picture here, he totally healed this wound. He healed it beautifully, actually. And his thoracotomy wound is also healed. And again, I've only seen him I saw him on the day of discharge. He was not on any oxygen. He was on room air. He didn't have horrendous pain, but I had proposed to him that I was going to fix his ribs. And then, this was a kind of interesting character. Like I said, he was a veteran. He was very funny. He was always telling us jokes and stuff. And I think he got it in his head that, hey, this surgeon is going to fix my broken ribs. And every time he saw me, he was like, hey, when are we doing this? So I'm excited to see him in the clinic, but I'm also hesitant to want to, take him back to the operating room that he's doing so well.
Yeah. Well, I would share that hesitation. Maybe somebody that just needs to be followed for a while to see what sort of disability he develops. But I'm not sure a flap, a muscle or a myocutaneous flap is really going to improve his lot. I think most of us think of these sorts of injuries as requiring bony stability, and maybe the flap is an adjunct. But I think if his ribs haven't been destroyed or removed, even if there's mal or non-unions there, a bony repair makes the most sense to me.
And we're talking, so when I was talking with the plastic surgeon, it was when this, large kind of wound was there. And I was planning to have him jump in with me from the get-go. And then the plan kind of shifted once, the wheels fell off and this guy was hemodynamically unstable when I came in on Monday morning. So unfortunately, the original plan, at this point, I agree. I don't think I would need, any plastics or any other help from that regard, because the wound has tissue coverage. But if you guys were going after this from the get-go, would you entertain having, a plastic surgeon come in to help for tissue coverage? Or would you, like Dr. Forrester said, just maybe, like you said, retrospectively, this wound did come together relatively well. Would you just kind of undermine some of these tissues and try and bring things together? Or what would be your plan of attack if the patient wasn't unstable and we didn't have to go down like the thoracotomy, emergency surgery type road?
Well, I'd like to hear what Dr. K and Dr. Forster have to say, but I would probably just have repaired this primarily. I would have plated, even in the setting of contamination. It's not like he fell into a porta potty or a porta toilet. This is sure, it's contaminated, but you don't have a lot of debris in the wound. You clean it out, you plate them, and the overwhelming odds are that the construct will remain infection-free and heal fine. Could it pus out? Sure, but not likely. And if it did, you would remove it after a couple of months when the healing had taken place. That's my opinion.
Yeah.
I was getting some pretty strong pushback from some of the partners, and I'm the low man on the totem pole, so I didn't want to be too cavalier.
Yeah, I would probably plate as well. I would probably actually utilize a lot of the wound that you have there. And then in the process of getting exposure to put down your plates, you're going to raise flaps anyway. You're going to have great muscle coverage over your plates. And I would have probably just done the plating at the same time. I think the risk of infection in the case you described is actually pretty low.
Pretty low, yeah. And we had him on broad spectrum antibiotics, in the interim. Did the patient have any issues with shortness of breath? No, like we said, when he left, he was on room air. And were his complaints mostly pain related? Yeah, when he left, like I said, he was really doing quite well. Very resilient 70-year-old gentleman. And then I think extracurricular coverage plus doing plates is opening too many doors. I like the question with the plates. Yeah. And what would you do? My other question was, and maybe I'm going to play this video again. What would you do with these bony fragments that are kind of in this wound? And maybe it's hard to tell from the video. I don't know. I'm going to play this again. That fragment of bone there is almost free floating, or it's almost, cartilaginous because it's right at the junction. What would your guys' recommendation be with that?
I used to debride all of that stuff, thinking that it was non-viable and it was going to be a problem. But I've changed my thinking about that. If it's, we take bone grafts from their iliac crest, they're completely devascularized, and we put them in between bones and they heal. So unless it was, unless it was completely non-functional or it didn't have any structural integrity or whatever, I would leave it there.
Okay.
As a substrate for bony healing. Joe,
would you go right to the sternum here too with these extra thoracic plates?
Yeah. I would probably bring it all the way across, like a big plate all the way across. I'd take your comminuted fragments, and if you can attach them to the plate and bone construct, I would do that. But I think you got good runway on the sternum, and you got good runway laterally. So I wouldn't see a problem with that.
I think I'm going to weigh in here for a minute. I think hindsight is always 2020. It's really easy to see the end of the story and then go back and maybe change course or do something differently. I'd asked about IR because there's a couple of places in the hospital you can go with a bleeding patient who is unstable. And with our rapid transfusions now, IR is one of them. The hemothorax itself, I think that you've got a couple of days before you really have to worry about clearing out that blood. He may have played out better to do IR. Only the intercostals, you don't know where the intercostal is bleeding. And it can be difficult sometimes to get control of those operatively without getting a bigger and bigger and bigger thoracotomy. So that the IR may have avoided the thoracotomy itself. And then I agree, I would have plated them on the index admission, especially if you can get muscle coverage. And then depending on whether or not you get your skin covered, you can put a wound back on that. And they generally will do quite well. I think you did great, and I think you made reasonable medical decisions along the way. It's just another option for how that could have played out.
Thank you.
Gary, you raise a great point. How successful are our colleagues in IR in identifying and cannulating individual intercostal arteries? I've never had an intercostal bleed successfully coiled. Have you?
Yeah, with IR, you're talking about for just intervention through IR?
Yeah, for an intercostal hemorrhage.
Yeah, I mean, that's been my go-to, both in fellowship and then in training as I go to them first. And I haven't had hundreds of them, but I've had a handful of them.
Probably just a gap in my experience, but I just haven't seen it. That's good to know.
I feel like that's where they end up bleeding from a lot of times. And I've seen a few of these where it's like a random bleed. It'll just, they weren't bleeding. There wasn't crazy chest tube output. And then 2 days into their hospitalization, all of a sudden, one of the fractures gets disrupted and causes bleeding. I don't know if anyone else has that similar experience.
I think there's definitely that subset of patients who, once they start moving around and becoming more active, particularly with the bad chest wall injury, if they're not stabilized, you can open up kind of Pandora's box of bleeding.
The intercostals retract, they just retract right around that rib in the neurovascular bundle. And so even though the injury looks anterior, the actual artery where you need to get control may have been, lateral or posterior by the time it retracts back.
All right. Well, Dr. Renda, thank you very much for a great presentation. I am now going to introduce our next speaker. Dr. Karabek is an assistant professor of surgery at Brown University and a trauma surgeon at Rhode Island Hospital. He's also the director of residence clinical research projects for the Department of Surgery and has a special interest in chest wall injury research. So, Dr. Karabek, I'll pass it over to you.
Hi, thanks for having me presenting our case. This is an interesting case that we had a couple of months ago. So I actually just recently had a follow-up with the patient and an updated story and added it to the end of this presentation. Let's make sure the slides. There you go. So this is a 22-year-old man, actually initially unknown age. We thought he was 17-year-old. So he went to the children's side of the hospital, and then we realized he's an adult. We transferred him back to the adult side. Backseat passenger, high-speed MVC, had seatbelt on, came in with respiratory distress, had bilateral needle decompression. Actually, the EMS crew had needle decompression in mid-clavicular line that failed or thought they failed, so they did also bilaterals and mid-axillary lines. Came in, had bilateral chest tubes right away, was persistently hypotensive in the emergency department. Fast exam was negative. We were thinking it's related to the chest, continued assessing him. The repeat fast exam was positive. Took him to the OR, emergent laparotomy, had a grade 4 liver injury. Did packing, Pringle, brief period of aortic compression, had small bowel mesenteric defects, no small bowel resection, did damage control resuscitation. At the end of the surgery, the anesthesiologist reported that he was bleeding from the sides of the needle decompression. So we went to feel in the chest wall, and as I felt on his right side chest wall, my hand sunk in inside his chest. So we realized he had significant chest wall trauma that you can see on the x-ray. It's not very visible when you look at the x-ray right away, but in hindsight, when you look at it after seeing the CAT scan, you can realize that it does show sternal defect with this gap from here to here. So we knew that eventually we're gonna do some chest wall stabilization, went to the ICU, resuscitated, got a CT scan since he has a significant blunt mechanism, and I'm gonna go quickly through the CT. And here you can see how he has an avulsion of his chest wall on the left side with an open pneumothorax and another avulsion on the right side as well. And the 3D recon of his chest mainly shows the sternal fracture with some fractures in the right side of the ribs. I'm going to show this one here. With significant dislocation. So eventually, patient 2 days later goes back to the operating room. Back's removed, liver was stable. We did wide drainage, closed the abdomen, no bowel resection still, and went back to the ICU with the plan that if he's stable in the next 24 hours, we'll take him back to the operating room. So the third day in the hospital now. Only problem is he's dealing with bad ventilation on a ventilator. So we knew that it's time to just take him to the operating room. The problem now, we identified the injuries. In addition, he had a left clavicle injury. So all his injuries were along the seatbelt, left clavicle, sternum, chest wall, and liver. So this is my drawing of what the injuries that we thought we're dealing with. So we have the sternal fracture that was pretty wide. We had multiple cartilages injuries. And then in rib 8, he had, actually I missed here, there's another fracture here. So he had a flail 1 segment of segmental fracture. So what are we going to do with it? What are our options? Before we went to the operating room, we had a small meeting for discussion. What are we going to do for the sternum? How are we going to repair the cartilages? Do we need to do also rib plating? He had pectoralis major avulsion on the right side. How do I put it back and stabilize it? And how do I fix the pleural defect, or do I need to? So my thought is that I wanted something like this. I want one plate that goes over the sternum and crosses over the ribs, or maybe every other rib. So ask the vendor in our institution. She mentioned something that they have something like this, and I thought maybe I can flip it 90 degrees. And can I use plates on plates? Can I screw plates on the ribs and then bridge them to this device so that I'm stabilizing the chest wall to the sternum? Eventually decided to go with just sternal repair and actually evaluating in the operating room, see what we're dealing with, and then go from there. So these are pictures from the operating room. This is the defect here. This is the head of the patient. He got his clavicle fixed first. This is the edge of the sternum. The other edge is under this flap here. You can see there's cartilages on the left side that are displaced. There are also other ones that are broken here. We use what we call big uglies. I'm not sure who uses them also, to grab the bottom part of the sternum and then approximate it to the top part. And then just did 2 plates, 3 screws on each side. That brought most of the chest wall together. And then we wanted to see what we're going to do with the ribs. This rib had the cartilages damaged, but then again, like I said, rib number 8 had a fracture here and fracture all the way laterally, causing segmental injury. So I ended up doing 1 big plate that went from the sternum. I didn't have a lot of landing zone under my sternal plate, so I had to go 1 plate with 2 screws, bypass the cartilage here and put screws on the side of the rib here, and then made a small cut laterally and to expose the lateral side of the rib, and screwed the plate all the way laterally on that same rib. So 1 plate went from the sternum to the segmental section of the broken rib and all the way laterally. When we were figuring out what we're going to do with the cartilages, my partners who are more experienced than me, similar like Michael, made commentary that I should not put screws in the cartilage because they're going to cause severe pain. So I shouldn't put any plates over them. Didn't feel that putting a plate and exposing the rib more here. Well, I didn't have any landing zone on the sternum for this rib. So what I ended up doing is making two holes in the rib, in the bone itself, passed a stitch from the hole in and out, and then back, and just basically pulled that rib chest wall to the place that supposedly well fixated to the sternum. So basically, that's what we ended up doing: 2 plates on the sternum, a stitch from 1 rib to the plates, and then a long plate on the rib below it. X-ray after the fixation, patient did very well. A few days later, he had some symptoms of chest pain and hypoxia. We thought he had a PE, so that we did a CT scan. I'm just showing it because I want to show how the plates looked at the end, and also want to pay attention. Want to make point that the soft tissue over the sternum was about 3.5 centimeters. That's going to talk about this in a little bit. But everything looked pretty good. The liver started healing well. Patient eventually got discharged, and then 2 months later, I got a call that his wound is opening up over the sternum. He of course lost a lot of weight. The liver damage was pretty significant, that his metabolism was pretty high, and ended up losing a lot of muscle and fat. And the wound didn't look infected, but they were open, and I didn't know exactly what to do. Let's see here. When we repeated the CT scan, the distance between the skin and the plates now is 1 centimeter. So I couldn't feel there's no exposed plates, couldn't feel the plates in the wound, but of course concerned of exposure of the plates and possibly getting infected, which is pretty bad, ending with mediastinitis after the save. So gave the patient 3 options: wet to dry dressing, vac dressing, or taking him back to the OR and excising all of this, or the wound, the edges, and repairing him primarily again. Ended up with wet to dry because his insurance didn't approve the vac, and he's healing, but very slowly, and I still don't know if I'm going to end up in the operating room to debride this wound. So learning points for this patient: early stabilization was mostly for the deformity and an open pneumothorax in this case, and not just for pain. It did help get the patient off the ventilator soon. Sternal repair options, I was looking for something fancy, but going with the old 2 plates. Of course, we did 2 plates, leaving space in between in case the patient needs a sternotomy in the future. That's been what I was told for years to do. Don't know what to do with the cartilages in the future. I don't know if this suture from the rib to the sternum is enough. I'm actually want to see what you guys think. And the nutrition and malnutrition is very important in this case. In hindsight, I thought I should have focused more on his nutrition. He's taking protein supplements, protein shakes, but with his liver injury, and most of these patients will have multi-system injuries, they are going to lose a lot of fat and a lot of muscle in their body. And so maybe in the future, when I plate somebody that in an area that doesn't have a lot of padding over it, should consider that, and maybe a flap over it, or again, consulting plastic surgery in this case, waiting for the wound to open. I don't know, but I really hope that this guy doesn't end up with an infected plate and having to go back to surgery.
Awesome. Great case, Dr. Karabek. This is going to generate some discussion, I imagine. I guess my first thought is that I would probably let that wound heal in as much as possible before going back in to do anything with the plates. Give it some time, particularly if he's not sick or showing like overt signs of infection. But we'd be interested to hear what others have to say. Carrie has a question asking about the suturing of the rib, why that one and not the rib above it too, and very cool idea.
So when I plated the rib number 8 and went to rib number 7, well, looking at 7-6, I felt that number 6 was pretty much closer to the sternum, and I just wanted one extra. I wanted to feel comfortable that I'm bringing the chest wall back to the sternum. I could have done the same thing on 3-4 ribs, but it was more of an experimental. I came up with it. Didn't really feel that I should do this on multiple and have multiple failures. Let me fail with and then see how it goes. And then it pretty closed the space pretty well that I didn't even feel that I need to do anything with the pleura. By the way, I didn't mention his pec muscle. We ended up actually pulling it a little bit towards the left side. So when we sutured it back to the tissue, we covered the plates with that, and I felt that coverage also provided stability of the open chest, kind of with the separation in the cartilages and exposed pleura. Bringing this back helped me cover the chest wall. So so I thought maybe one rib only to the sternum, and then hopefully he will scar over it. I don't know.
I'd be interested to hear what Dr. White has to say, but I will commonly plate, not commonly, but I'll plate into cartilage if need be. Okay. I haven't had any real problems other than that you have to accept the fact that it's not going to be as stable a construct as the bone, and you may get a plate failure there in the future. But from my standpoint, I have no hesitancy to plate into the cartilage.
Would you do unicortical or bicortical plating?
I would do either. I would feel comfortable doing either.
Okay.
Yeah, I would agree with that, Joe. This is a fantastic case. I love the creativity. I mean, you obviously were, there's no way to prepare for a case like this. No one's seen one exactly like it. You have to think on the spot. I love the way you did that. I probably would have just gone bone to cartilage on that other rib with a plate and satisfied myself with that. It's probably a more durable construct than the wires to the sternum, but I'm not sure. But if these plates, if they're ultimately get infected, a few months from now, you take them out and the patient is healed and they do fine. So I wouldn't. I don't think in a case as dramatic as this, I wouldn't consider a secondary operation to remove hardware as a failure.
Okay.
I guess that would be my point.
So when we talk about the cartilages, nobody has seen chronic pain from screws into the cartilage.
No.
Okay. So my boss is just messing with me.
I've definitely seen chronic pain. In fact, Dr. Anand is getting ready to present a case when cartilage isn't, when there are problems with cartilage not being secured. So
not healed. Yeah.
Yeah.
All right. Well, again, Dr. Karabek, thank you so much for a great presentation. And I think that you are going to be nominated the CWIS Artist in Residence for those drawings. So get ready for us reaching out. With that, I'll turn it over to Dr. Anand, who is a PGY3 surgery resident here at Stanford. So Dr. Anand, it's all yours. And you're on mute.
There we go. All right. think everyone should be able to see that right now. So my name's Ananya. Like Dr. Forrester said, I'm a PGY3 surgical resident at Stanford, interested in trauma, critical care, and acute care surgery. Thank you very much for the opportunity to present today a very interesting case that Dr. Forrester actually participated in and oversaw. So I'll go ahead and get started. So the case is a spontaneous costal margin rupture and intercostal hernia. So the patient is a 70-year-old male, has a remote history of a right-sided thoracotomy over 30 years previously, secondary to complications from a walking pneumonia, who noticed a mass and swelling over his left chest after bearing down for a bowel movement more than a year ago, or a year prior to his presentation. He reported feeling something tear, and since then had had continuous severe left chest wall pain that was present at rest and with movement. He presented to our clinic a year after his incident. He was a former 25-packer smoker and polysubstance user. Interestingly enough, he had seen multiple providers for this problem and had actually been referred to psychiatry for phantom chest pain complaints. His comorbidities included type 2 diabetes, obesity, atrial fibrillation, COPD, hypothyroidism, and asthma. And he took metformin. He was on Xarelto for his atrial fibrillation, metoprolol, and Synthroid. So when he came finally to our clinic after seeing, like I said, multiple different providers and being told that this might be just some phantom chest pain, on his physical exam, he had significant tenderness to palpation under his left costal margin, and there was a significant notable and palpable deformity of his left costochondral junction and costal margin, and he had discordant movement of his chest wall with respiration. At this point, and he had been seen by Dr. Forrester in clinic, it was decided that he needed to have an operation for this problem, but we went ahead and got a CT of his chest without IV contrast, and I'll play this for you here. And so it does show herniation of the lung in the intercostal space between the anterolateral left 7th and 8th ribs, as you can see coming down. But the read by radiology was actually that there was no definite associated osseous or costochondral abnormality. So as we're coming here, you can start to see this left-sided intercostal hernia coming into view. And then on the scalp imaging, you can see once again the presence of this intercostal hernia. So like I said, we decided that he needed to go to the operating room in the setting of his more than a year of chronic left chest wall pain. The operative approach that we took was a left thoracotomy directly over his incisional hernia site. And in the operating room, we noticed an intercostal hernia between the left ribs 7 and 8 with a grossly disrupted costal margin. The method of repair, which I'll go into detail with shortly, is we did a bi-level Edwards quilt mesh. And for the costal margin repair, it was a slip rib suture repair. In addition, we did a VATS-assisted intrathoracic cryoneurolysis of nerves 4 through 9 with a placement of a 24 French blade chest tube and then a drain over his mesh overlay. So I can't take credit for those drawings. I think that's Dr. Forrester. But we initially started by making a thoracotomy incision over the intercostal hernia, which we carried down to the fascia over the left latissimus dorsi and serratus anteriorly. We raised myocutaneous flaps inferiorly and superiorly, lifted the serratus off of 2 ribs superior to the defect, and the external oblique was lifted off ribs 8 through 10 inferiorly. We had our anesthesia colleagues cease left lung ventilation. And at that point, we were able to fully observe and appreciate the intercostal hernia. We divided the attenuated intercostal muscle and hernia sac between the 7th and 8th ribs and entered the thoracic space. And subsequently placed a metal 12 millimeter port at the 5th intercostal space and performed VATS-assisted intercostal cryoneurolysis, as I mentioned before, and placed our chest tube. So this is, I think, where we get to the really interesting part, the actual repair of the defect. So the defect ended up measuring from 2 ribs cranial to 3 ribs caudal, 18 centimeters, and then the anterior to posterior dimension defect measured about 15 centimeters. We chose a biologic mesh, 20 centimeter by 20 centimeter, which we trimmed. And here, the leftmost image on your screen shows where we placed 18 1.0 Ethibond sutures throughout the mesh. We correspondingly drilled biocortical holes through ribs 8 through 10. And you can kind of see the placement here in the second image of the Ethibond sutures in relation to the rib, so where the star marks the intercostal hernia defect. We then parachuted the mesh into the thoracic cavity, and the sutures were brought out on the anterior surface of ribs 6 through 7, so the anterior aspect of his intercostal hernia defect. The ribs were then, as you can see down in the bottom right of your screen, the rib refect was reduced with placement of 8 tiger tape sutures, which span the defect in a simple fashion, going through the pre-drilled holes on the 8th rib and encircling the 7th rib. And these were tied down in place and secured. And then the Ethibond sutures were also then secured, thus keeping the mesh in place. And then we used VATS to once again take a look from an intrathoracic view of the underlay mesh, which you can see at the very bottom of the screen, with the star representing the mesh and the circle representing the diaphragm. And it lay very well against the cavity. And then we had the lung reinflated and removed the thoracoscope and the port. And so given that this is a technique that incorporates a mesh underlay and a mesh overlay, once the underlay portion of the procedure was complete, we then moved on to the mesh overlay. We selected a synthetic mesh and trimmed it, and the long tails of the Ethibond suture were then passed through the overlay mesh using a Carter-Thomason needle, and the mesh was then secured. The wound was washed out with vancomycin and a tobramycin solution, and then a Blake drain was placed. The skin, the muscle and the skin was then repaired in layers. So in terms of our patient's post-operative course, so he was sent to the SICU for overnight monitoring. He did have some hypoventilation with PCO2 in the low 50s, but this was likely secondary to his baseline known COPD, and he was transferred to the floor the very next day. We continued him on ANSEF until post-op day 7. He was able to be maintained on his baseline home level of oxygen, which is 2 liters, and was discharged on post-op day 7 with multimodal pain control regimen. The chest tube was removed on post-op day 2. His drain was removed on post-op day 6, so he went home without any tubes or drains. And his length of stay in total was 8 days post-operatively. He was seen in clinic 1 week after he was discharged, at which point he had some numbness, which corresponded to the cryoneurolysis that we performed. But there was no evidence of any costal margin rupture recurrence, and he was actually breathing well on room air. He did come back to the ED about 1.5 months post-operatively for some chest pain, at which time they noticed a small left pleural effusion, and then was seen by us in clinic another 2 months after his post-op discharge, at which point his overall pain was improving. And by 3 months post-operatively, he was more active, his pain continued to improve, there was no evidence of recurrence, and he was actually able to start drawing again, which was a hobby of his that he had been unable to do when he had had severe pain prior to his repair. So some of the learning points from this presentation, at least learning points that I picked up on. So costochondral injury typically occurs in the setting of a blunt trauma, but in this case, it actually happens spontaneously. And some of the literature suggests that it can occur in relation to severe coughing, sneezing, retching, or even when a patient undergoes CPR in the setting of that kind of a blunt trauma. Costal margin rupture can be associated with the development of intercostal hernias, as in the case of our patient. And CT scans can aid in the diagnosis of these kinds of injuries, but physical exam is essential. In this particular case, our physical exam actually informed our decision to go to the operating room more than the CT scan, where the read actually didn't remark on any kind of costochondral disruption or injury. And that this double layer mesh repair provides a very good repair in the setting of costal margin rupture with intercostal hernia. On the right side is a Sheffield classification that was proposed by Guzman et al. In 2018 that classifies the 7 types of injuries involving the costal margin. And in our case, if you follow the trajectory, we did have a costal margin rupture. There was no diaphragmatic rupture, and there was intercostal rupture. And so he had a costal margin rupture with an intercostal hernia. And lastly, this is just another schematic from Edwards in 2020 that once again just demonstrates the double layer mesh repair that we performed, which based on our experience post-operatively with this patient who was actually seen in clinic not too long ago, I think a week or so ago, is doing quite well.
Awesome. Well, thank you so much, Dr. Anand. I've been able to answer a couple of questions in the chat, and this may be a kind of a tough question for you to answer, but I'm happy to field it depending on what you think. But what do you think about the antibiotic duration?
So let me make sure I was. So I think with his antibiotic, we had kept it on because he had some erythema around his incision site. And so we wanted to make sure that we sent him out once we knew that he didn't have any kind of a wound infection. But I'm actually not sure in terms of what kind of the standard of practice is after these kinds of repairs, what we would do in terms of our antibiotic regimen. I'm not also sure if this question is addressing kind of what we did intraoperatively with our antibiotic irrigation as well. But in terms of our post-operative antibiotics, when we gave him Keflex, that was, I think, the rationale.
Yeah, I'll be honest, it was straight up fear. I put a lot of mesh in there, and I really did not want, because of how sick this guy was, for the mesh to get infected. So it was most definitely just fear, not data driven. I think as we do more of them, I will probably be more aggressive about getting antibiotics off early. But yeah, as this was the first one that we had done here, I felt like I kind of had to be more aggressive with the antibiotics than I typically do. I would also like to say that for this case, this required a ton of preoperative planning. And I wanted to thank Dr. White, who helped talk me through what he did with a similar patient, as well as Dr. Edwards, who I had numerous talks with before this case was even booked, because it is a really complex procedure to kind of think your way through. And I think the more people you have looking at the scans and thinking through your methodology about how you're going to do the case, the better off you'll be, because they are quite challenging. So,
Joe, can I make a comment or two? And Ananya, that was a terrific presentation. Thank you so much. We're seeing these patients now not infrequently. Joe, you probably see a few of these a year now, I'm guessing, and so am I. And they all have one thing in common. That's that they disrupt their costal cartilage, and it allows the splaying of ribs 7 and 8 or 8 and 9. They all have a gap or a triangular shaped defect that needs to be either covered or reduced to it's to a more normal anatomic configuration and held in position there with some sort of I would like to say tension-free repair, but they're never tension-free because the chest walls have remodeled with this defect. And so my question is more about the costal margin defect. Obviously, this patient had one. You recognized it. You reduced their ribs in parallel, but did you do anything about the costal margin? Do you think it's important to do anything about the costal margin defect itself, or is this repair enough? What do you think now that you've done one?
Yeah, so Nanya touched on it briefly, but what we did was we actually did essentially like a modified Hansen procedure for the costal margin. And so I brought the tip of the costal margin together with Ethibond sutures in the same way you do a slip rib case. Did it help? I don't know. It made me feel better. And I was like, if I'm in here doing this, this big case, like I want to make it look as perfect as possible before we close, because he's not the type of guy who tolerate a second operation particularly well. So I did, but I don't know if it had much of a difference.
If this patient presented acutely, they squatted on the toilet or they coughed vigorously and they came in and you saw them within weeks or days of their injury, would you affect a different kind of repair?
I probably wouldn't. I'd probably do the same thing. if it was as dramatic as his was. I mean, when I walked into the exam room, I was fully expecting to tell this guy, like, there's nothing I'm going to do for you. Like, this is something that's like super tentorial. And I walked in and I pressed on his chest wall, and I was like, you have a problem. We need to fix it. Like, this is a clear anatomic issue. So if someone came in acutely, I'd probably do the same thing, particularly if they're having discomfort with it.
I guess what I meant was, if you repaired, if it was acute and they hadn't remodeled their chest wall with this deformity, could you repair their costal margin alone? And would that be an adequate repair, or do you think you need to do the whole Edwards procedure for an acute rupture?
Gotcha. Man, that's hard to say. I think it would kind of depend on the degree of muscular disruption. If it was a really bad trauma and the intercostals were completely avulsed, then I would probably do the Edwards patch. If the muscles were just a little bit disrupted and it looked like they were going to be able to heal okay, then I probably wouldn't, and I'd just repair the costal margin. And then I see a question from Dr. Wolf, guessing there's few described cases out there. Yeah, there's not a ton of cases, but I would second Dr. White in saying that we are increasingly seeing these patients. And I would encourage you, if you do see those patients, to definitely reach out and chat with someone who's done one of the cases before, because it really helps to talk through some of the challenges. And hopefully within the next year or so, we'll be able to have some sort of registry for these patients, because I do think it would benefit from some sort of multi-institution review, given how infrequent they are.
I guess my biggest question specifically is to your onlay mesh that we used, and I know Dr. White referenced it too. And I know from abdominal hernia surgery, there's very hard to get tight and flat and beautiful like you really want them. So do you think you're getting a lot of benefit from the onlay in addition to your underlay?
I suspect so, because as the underlay is incorporated into the chest wall and that biologic is slowly broken down, I imagine there's some laxity that develops, and that plus probably laxity that develops with the tiger tape over time. It's just one additional kind of pepperoni on the pizza to keep everything together. And it looks like Sarah Ann's saying that there's a survey-based research project regarding cost of margin to be released by email soon. So keep an eye on your inbox. Perfect timing.
Yeah. Well, I was just going to comment about that actually. So Dr. Edwards has been collecting all of the cases that he's done. And I think there are kind of pockets of them, like Dr. White was mentioning, and, some other folks that have done them here and there. I know Dr. Crisco's done one, and like you say, or like you mentioned, there aren't a ton of them, but I think, we're looking at what Dr. Edwards already has and the level of detail that he has within his data collection, and trying to decide if that it's in Excel, and trying to decide if that will move to RedCap or what, that then CWIS will start collecting those as well, so that we can really try to study these patients overall. So if you have done one, or if you do one in the future, certainly let us know. And then a survey will be coming out soon so that we can start to share those.
Awesome. Well, thanks again. I just wanted to take this opportunity to thank all of our presenters. 3 excellent cases generated a lot of discussion. And I would encourage everyone, if you have more questions that come up, to post it over into Slack so we can get some back and forth going in Slack. Also, just a reminder, I shared my screen. These case review series are available monthly. I put the link there. Just a reminder, you can see all of the prior case review series. So if you want to go back and review a case, it's all there. Also, the ribcasts and riblets are being released monthly, and the fracture line is available weekly. So there's a whole lot of rib info out there for all you rib enthusiasts. And with that, we will end this month's case review series, and look forward to seeing everyone next month for another great case review series. So take care.